if you want to get to it, let's put 2 minutes on the clock and prepare ourselves for another round. Time starts now. Emma Wilson, a 25-year-old woman, presents to the general practice with complaints of palpitations. She describes episodes of rapid heartbeats that occur spontaneously and last for a few minutes. She reports occasional lightheadedness during these episodes, but denies any chest pain or shortness of breath. She mentions that her symptoms tend to occur more frequently when she is stressed or anxious. She does not take any regular medications. On examination, her vital signs include a temperature of 36.7, blood pressure of 120 on 80, heart rate of 95, and I'll change that here, sorry, that is regular, and a respiratory rate of 16. What additional aspects of history could clarify the likely cause of her palpitations, listing 4 on history? All right, time is up, and let's get to it. This is taken from the AJGP Approach to Palpitations paper. It was from 2019. I try and avoid references from more than 3 years ago, but there wasn't anything really specifically on this from RACGP themselves, and so I thought this would be the next best thing. Now, they did really focus in on the cardiac aspects, and so the marking rubric here, I think, does have a little bit of flexibility to it if there are questions outside that. But the recommended questions there were, is there any family history of cardiac disease or arrhythmias? That would be grouped together. How frequently is she experiencing palpitations, given they haven't actually said that in the STEM? How quickly do the palpitations come and go? Is it a sudden onset or a gradual onset offset? Is the heart rate regular or irregular? And I do apologise, I'll have to fix this up on future presentations. History of substance use, that would include things like caffeine, alcohol, illicit drugs, and again, they would be grouped together, and so I'd be avoiding putting multiples of that. Has there ever been an associated pre-syncope or syncope? Has she ever had any pre-existing cardiac conditions? Because they haven't specified any history here. And is there any history of sleep apnea? Is there any history or symptoms of thyroid disease? So some excellent ones coming through here. And any heat intolerance, any pedal edema. I would be a little bit, well, actually, no, I see what you're getting at. So first one's getting at thyroid disease. Second one could be a sign of thyroid, more likely to be heart failure. I think that you would be putting down potentially in a 25-year-old who's otherwise well, I would potentially try and source things from elsewhere. Any past history you've got, fantastic. And caffeine intake in a day, very good. Likewise, history of stimulant intake, such as methamphetamines. I really like you're giving a specific example as well and showing that consultant-level knowledge of what the things are that you're looking for. History of congenital heart disease. Oh, chef kiss, perfect. History of menorrhagia, very good. And tying in as well, I won't spoil the fun. And history of hypothyroidism, excellent. Very good. Now, there is a note here in terms of heart rate would not be a history answer, rather a physical exam point. Maybe previously, yes, but this day and age, everyone's wearing some kind of smartwatch or smart device that's measuring heart rate. And I don't know about you guys, but I frequently get people coming in saying, oh, look what my Apple Watch tells me is going on. And so I think it's actually reasonable for a question on palpitations in a young person who potentially could be checking her own pulse as well. I think it is actually fair game to ask about the rate. But just my opinion, I guess. All right. Of course, let's get to it, though. We have 2 more questions to get through. So your time starts now. Her symptoms are currently daily to second daily. What initial investigations would be appropriate? Select 6 investigations. All right, time is up, and let's get to the answers. A, B, C, F, K, M, O, and P. Now, these are all the recommended investigations from that paper previously mentioned, and very happy to say you guys have absolutely nailed it. B, C, F, O, P, and correcting yourself there for a M. So very, very good. And again, nailing it, A, C, F, M, B, K. Very well done. Now, I think the thing that kind of seals the deal between a Holter monitor over a continuous loop monitor is the fact that the symptoms are daily to second daily. If they're a bit more spaced out than that, you probably would consider a loop monitor because you're less likely to actually capture one of these events on a Holter. But otherwise, absolutely fantastic. Okay, now coming into, of course, the final question for tonight. Get ready. 2 minutes on the clock and your time starts now. Her investigations all return within normal limits. You're feeling a shift in the local emergency department when you see her. She states she is experiencing her palpitations, which have persisted for 15 minutes. You record an ECG shown below. What management actions would you take? List 4 management actions. time is up and some answers coming through. Very good to see. And I don't know why I can't get rid of that 3 that's there. It's there forever. That's where it lives now. It is our eternal 3. Now, of course, this is a supraventricular tachycardia, or often interchangeably used with atrioventricular AVNRT. Narrow complex tachycardia, it's about 150 beats per minute. There's no visible P waves. We do have some, looking up here, some pseudo R waves as well. But again, if you're picking up there's no P waves, you've got that tachycardia picture. It's saying that the tachycardia is originating from above the bundle of His. There is our answer. How do we manage that? Of course, with lots of toys. And the modified Valsalva, I love it. I've done it plenty of times. I've found it very successful. The statistics say it's just shy of 50% successful. I've probably had better rates of success than that, and so I tend to be, I think, a bit more pro it, but there you go. So this would be where you're thinking through, well, what are the things I need to be doing that safely as well? And so you would be having this patient with continuous cardiac monitoring, frequent blood pressure monitoring, because that's going to tell you if this patient's changed from stable to potentially unstable. Now, the risk of that happening is relatively low, but we're thinking we're going to be bringing out some of our big guns later on, and so we want to be prepared for that. Now, we would be inserting a large bore IV cannula into a proximal limb location. The answer coming up shortly as to why we're doing that. And one of the interesting things, and I've seen this several times, sometimes the actual shock and pain of having the cannula inserted, particularly if it is a large bore, is enough to give them that little bit of vagal stimulation and can actually resolve the arrhythmia on its own. Take some of the fun out of it, but there you go, the patient feels a bit better. Now, we would then be trying the modified Valsalva maneuver. If you haven't seen or done this yourself, super easy to do. In a GP setting, you could do it quite safely as well, where you get a syringe and you basically get the patient to try and blow out on the syringe, have in a semi-recumbent position. Get them to do that for 30 to 45 seconds, as hard as they can. They'll be bright red in the face. You'll see the neck veins distend, and that gives them that vagal stimulation. And as soon as they've kind of met that time frame or about to give up, lay them down flat, lift their legs up to at least 45 degrees and hold it there for about 30 to 45 seconds. I think you tend to get slightly better responses if you leave it for a full minute, but the recommendations are for that 45 seconds. And then you can lay them onto their side, slowly sit them back up again. That's often all you need to do. But of course, if that doesn't work, if you haven't had success with that, you can try and repeat it again, but then we're bringing out the big guns intravenous adenosine, which does have an incredibly short half-life, which is why we insert it through a proximal limb location. You're wanting it right up in the cubital fossa so that it's having a short a path to the heart as possible. So you've got Valsalva maneuver, and perfect, and I like you've kind of questioned there, spelling, that's fine. From that, it's very clear to see exactly what you're wanting, so even if the spelling were incorrect, someone marking that, they've told us many times, they're not worried about spelling. If you can convey the point you're trying to get across, if you can show that you know what you're trying to say, that's sufficient. Now, carotid massage, this is a bit of a tricky one because it really depends on which guidelines you're looking at as to whether or not they're recommended anymore. And so I don't have an official answer from the college, and so I'd be hesitant to say yes or no to that. It's usually the kind of more crumbly patients where there may be carotid plaques. You would definitely be not keen to do that and potentially flick a clot off. Likewise, infants and very young children, it's not recommended anymore as well. And so there is that kind of ambiguity between infant to crumbly adult. So I think I would probably steer clear of that until we did have a proper answer through. Now, prepare for defibrillation if required. I think you could just get away with saying attach cardiac monitoring because I think you would be pretty hard pressed to need defib pads. If anything, you may end up with a bradycardia or look, I think it isn't unreasonable. I don't know if it would get you a mark, to be honest. But adenosine intravenously, yeah, definitely. That'll get it. Cool, okay. And we've got here the vagal maneuvers, adenosine intravenously. If vagal maneuvers fail, perfect. Continuous monitoring, fantastic. Arrange follow-up in 2 or 3 days for further workup of palpitations. Now, you may get marks for that because one of the things it hasn't specified in here, is here. What management actions would you take? It hasn't said immediate management actions, which would necessarily kind of focus you really in on this. I think if there's other things you could put, I'd put that preferentially, but if you're struggling to think of things to say, it may get you a mark. Would referral for electrophysiology study give a mark? Not in this instance. I think that really they're trying to focus in on what are you going to do to address this immediate action. So similar to the last answer there, if there's other things you could put, I'd probably put that preferentially. If it was more of a follow-up type question, then I think you'd be well meant to put it there. And yes, that's true. Wolff Parkinson White can look like SVT. Adenosine will send them into VF as far as you know. Yes, which is why I tried to give you something that was very clear-cut, not Wolff Parkinson White. That was a very, I think, hopefully very clear-cut SVT. So I understand the hesitancy. And look, as I said, I don't know if you would get a mark. It's certainly not a bad idea, and I've seen a lot of places that do put pads on for these things. But in a young female, don't know, can't guarantee, and so I'll just be hesitant to say yes or no to that one.